Adjuvant Respiratory Therapy by Brian Walsh.
Okay, I'm going to talk to you guys a little bit about adjunct therapies, and then I'm going to kind of mix it up a little bit because I'm going to kind of blaze through stuff that I was planning to talk to you about, and then actually kind of open it up for the audience, because adjunctive therapies are only as good as the therapies that you actually can provide. And I don't know all the therapies that you can or can't provide, and so I'd like to have a little discussion towards the end about it. I will tell you just a few things that we've seen in our practice change. And I'm first going to start with kind of aerosol therapy. In aerosol delivery, as Natalie mentioned yesterday, is that some of the inhaled medications we give out of desperation, sometimes to help improve pulmonary functions. But largely it's not because of the medication itself that does or does not work. A lot of times it's because of the delivery. So getting it to a neonatal's lung is quite difficult, as you can imagine. And so deposition is one of the key factors that we have to make sure that if we're delivering an inhaled medication, potentially one that's expensive, we have to make sure it actually gets to the lung itself. And it depends on many factors. And sometimes you don't want the medication to get all the way to the distal lung. You actually want it to land in the upper airway for croup and those types of things. And so it's something to think about. But particle size is important, the flow rate and depth of inspiration, and the delivery devices. And we have several different types of delivery devices. I don't know what you guys have here. Do you have small volume nebulizers that you can give medication through? Yes, no, so, yes. MDIs, puffers? Okay. So you have both. And so there's all types of air chambers and those types of things. Air chambers or MDIs are something that have actually become more favorable than small volume nebs in our practice for a while now, until a new technology that I'll tell you about in a minute that is actually challenging that a little bit. And so people have done the comparison between small volume nebs and MDIs and show that they're pretty close to the same. And the deposition is probably good, if not better, with a spacer. In other words, if your hand-eye coordination is really good, you probably can do it okay without a spacer, but we recommend pretty much a spacer for all applications for that method. And spacers come in all different sizes and uses. And so I grew up in Virginia, and I remember actually seeing inhaled medications being given to racehorses and things like that. I got this picture off the internet, but I do actually see that this is an application that people do use. Sometimes we spend more money in racehorses than we do in people, believe it or not, in technologies. And so, in fact, just kind of an anecdote, some people have said that high-flow nasal cannula was actually initially developed for racehorses, because when they would race so much, they increased their minute ventilation, and all the dust from the track and increase in minute ventilation would actually dry out their mucosa, and they would actually have cracks and bleed. And so if you pre-hydrated them before a race by doing this high-flow nasal cannula, or a system that was developed to give them lots of heat and humidity, that it would actually reduce that. I don't know how much of that is true, but it's something that you hear people talk about. MDIs with mask are something that we obviously prefer for infants, and it's something that can be done, and they come in all different shapes and sizes and forms. There's even MDI chambers for tracheostomy tubes, and so you want to make sure that you're aware of those. When it comes to small volume nebulizers, there's also all different shapes and sizes, and a lot of times it is what you pay for. And so a lot of times if you buy a cheap nebulizer, you get a cheap aerosol, and sometimes that's okay, and sometimes it's not okay. when it comes to that. Also, cooperation, particularly with our infant toddlers, is quite difficult. And so having incentives, as we call them, with bubble, mask, fish, all these different types of masks, we can actually make them or they provide them for smaller kids, which is kind of interesting. So I'm going to stick to smaller kids because we're talking about a neonatal conference here, and so there's a baby conversion kit a lot of times for these smaller kids that have a nice tight seal. The little bit slightly tight seal is actually a better aerosol, and so you can actually provide improved. But this is difficult because you can imagine that the child's going to want to move their head away from the mask, and so it can be difficult. And in some of our CF education, we actually get these kids really early and start applying chest PT and mask and stuff, knowing that in the beginning they're going to fight it, but you have to be persistent. And before long, they actually will start taking the mask. It just becomes part of their care. Doing it much later in life is harder because, just like all of us, we develop habits that we don't want to change often. And so, aerosol delivery through a tracheostomy tube is a lot harder, particularly for kids that have to lay down. A lot of times it can be done, but it's a little difficult at best, and so you can spill the medication. And those types of things, but they do make trach collar type apparatuses. One thing I want to discourage, though, is blow-by. And a lot of times people do this, but it's pretty much worthless. In other words, most of the aerosol gets all over the face, all over the body, and not really into the lungs itself. And so if you do that, I always say blow-by is for dummies, and that's why I put a dummy up here, because really shouldn't be doing it. You're just wasting precious medication and time a lot of times, and so you want to think about it. Aerosol therapy has come a long ways. So this is what we used to do with aerosol therapy: is put them in a huge tent and just spray them the entire body with basically the drug of choice, isoproterenol back then, and so it was something that was quite interesting. Inhaled medications are only as effective as the technique, and I want to kind of review just a little bit of basics about aerosol therapy before we jump into a couple medications. Is that in neonates is probably the hardest to provide because their minute ventilations are low and their airways are small. And one of our practices is that we tend to give adult doses of medications to neonates. And I know that's against probably everything that you were ever taught a lot of times, but if you understand physiology of minute ventilation, they basically wean themselves because a lot of the medication does not get to them, so you're continuously blowing it in their face. But if their minute ventilation is a half a liter a minute, and my minute ventilation is 5 liters a minute, who gets more drug? I do, not the baby. And so you don't necessarily have to wean it like you would like to think, is that it should be per kilo. Well, if you were doing an IV medication, that would be true. But for an inhaled medication, not necessarily true. And so 2 to 5 microns is kind of the ideal delivery, or what they call the respirable range. Unfortunately, this has only been validated in adults a lot of times. And so if you have less than 2 microns, it's called non-respirable, meaning it comes in and then goes right back out. And this is kind of an exception, I think, for neonates and endotracheal tubes. It's been proven pretty well that if you have an endotracheal tube and your micron is greater than 2, a lot of times it won't get to the distal end of the endotracheal tube. And a lot of our nebulizers produce aerosols in that 2 to 5 microns, so above that tube. And so that may be why MDIs may actually be a little bit more beneficial even for endotracheal tubes, is because it has a smaller particle size that can get to that distal end or doesn't collide in turbulent flow. Obviously, greater than 5 microns, that's when you get kids that will tell you they can taste the medication and then those types of things because it just deposits in the upper airway. Or if you were actually to take the medication, you'd actually be able to taste it. And so the one thing that's impacted our practice, and I just want to kind of throw out here to you, is the vibrating mesh technology. It's the company called Aerosol, and they're the only ones that make this. But I just kind of did a little pros and cons here because it is something that is kind of revolutionized our aerosol therapy, and in fact, it's actually getting people to consider whether I should go back to small volume nebs versus MDIs. And so it provides a high-quality aerosol through this micro pump technology. In other words, it doesn't add flow to the circuit, and I kind of highlighted that because that's probably the most important thing that we see from a ventilator perspective, is that I can put this in line with the ventilator circuit, and I don't add additional flow, which then allows me to still continue to monitor the patient and deliver the aerosol during that process. And so you can do intermittent dosing, or you can do continuous. It stays in the circuit a lot of times. Most of us put it on before the humidifier, so way back in the circuit, it sits there, and it works pretty well. Some of the cons, unfortunately for us, is that it's expensive, and it requires a device controller or electricity to actually generate this aerosol, and so it's not flow driven, if you will, so you don't hook it up to a flow meter or those types of things. And like I said, that's getting us to the point where we can actually reconsider inhaled medications for neonates because of the quality of aerosol that this device puts out and the consistency of it. And so I want to talk to you about something that I thought about just adding in here for adjuncts, and so I changed kind of my talk a little bit just from talking with you. Like, you don't have nitric oxide. So are there things that you do have that you could potentially use for someone who has pulmonary hypertension? So I wanted to throw out a couple that you may or may not have or may be able to get access to. And one of them is inhaled prostacyclin. And I want to kind of set you up for how we've discovered it in the U.S. For the use. And so there's a little motivation behind it. Particularly in the perioperative situation, is that nitric oxide was launched in 2000, and the company was kind of ill-prepared to continue to study patients outside of kind of the neonatal realm. And so nitric oxide got what we call FDA approved for use with persistent pulmonary hypertension of the newborn. And one of the things that we wanted to start using it on is patients who were not in that kind of FDA approval process. And even the kids that were in it, it was very expensive. And so the adult guys started exploring this because they thought they probably could get reimbursed for inhaled prostaglandins, prostacyclins in that patient population. Some of the advantages of inhaled prostacyclin is that the mechanism of action is a little different. And it increases the cellular NO. It seems to decrease PA pressures, and so they could monitor it pretty fairly. The therapists were familiar with how to do continuous aerosols, and so this was not a new device that they would have to incorporate into their practice. And so it was something like that. And so it did not require this elaborate delivery system, meaning it needed minimum education. It also doesn't take up a footprint at the bedside, and so a lot of times, I don't know about you, but our place, it's hard to get more equipment at the bedside. There's already too much equipment, and we're invading constantly the family space, and workers have a hard time getting around the bed. And so that was one of the advantages, is that we didn't have to bring another machine and set it beside the ventilator. You could actually put this in line with the ventilator. And so the other thing is that, and probably the biggest thing is that it costs $300 a day. And that is expensive. And so don't get me wrong, but it's much cheaper than nitric oxide was, which back then it was about $3,000 a day. And we didn't need to, it was a low-cost alternative for a short trial, particularly in the cardiac patient population. Some of the advantages of nitric oxide that people would argue is that there's a reduced risk of infection because you're providing a gas versus an aerosol. We know that anytime you aerosol something, you have the opportunity to actually be a vector for infectious material into the lung, and so you want to make sure they try to minimize that. It's less labor intensive. I think the therapists like providing nitric oxide because it's so much easier than an aerosol. PGEs requires refrigeration. It needs to be changed kind of every 3 to 4 hours, so it's pretty hands-on when it comes to that. And it has the potential to caused the ventilator to malfunction because of the glycine buffer that's in there, and so that's one of the problems. A couple other disadvantages of PGEs is the pH of it. It's pretty alkaline. So it has a pH of 10.2, and I'll talk a little bit more about that. It may lead to airway reactivity, improved distribution to the alveolar extremities in a gas versus an aerosol, and so a lot of times the gas can get there a lot sooner than the aerosol. It has improved PaO2 by comparison when people have looked at the differences between the two. When it comes to kind of inhaled prostacyclins, there's different mechanisms. And here's kind of the pro-cons of that, and the cost differences at the bottom is probably the key point in which we started to investigate inhaled prostacyclin. I conducted a case series on some kids in which nitric oxide and inhaled prostacyclins actually worked better. So it was something that we found pretty interesting. So what is the ideal pulmonary vasodilator? And so one that's obviously works. It's pulmonary selective. Some of you guys have been around a while. We used to use non-pulmonary selective vasodilators, and then you had blood pressure problems and all types of other issues that are going along with that. It needs to have a fairly short half-life, so if it's not working, we can take it off, and those types of things. Safe and cost-effective. So something I'm going to present to you is maybe in your mind, as we would say, is old wine in new bottles. And so something that PGE1, so prostaglandins, is something that I think you guys have probably used for a while. We all have used it for a while in a long time. Is that can you take that and put it in a nebulizer and actually get selective pulmonary vasodilation? And so some of the metabolism is here about how PGEs are actually metabolized, and a lot of this can be taken care of in the lung itself. So then you're asking, well, is it actually effective? In other words, can you do this? And so there's quite a bit of evidence out there, in particularly animal models, about pulmonary hypertension models that inhaling or aerosolizing PGEs2 and PGE1 is effective as nitric oxide in relieving pulmonary hypertension. There's been a couple studies in adults from that perspective as well. And I'll provide you guys these references at the end of the conference. And so some of the other ideas about the inhaled vasodilators that are on the market, so nitric oxide, PGE1, and prostaglandin 2 is here. And so inactivation is done by nitric oxide, typically in the pulmonary vasculature, and then PGE1 is in the pulmonary vasculature, hepatic for prostaglandin, prostacyclin. And so other things that you'll notice, the buffer. So when we talk about aerosolizing anything to the lung, we want to make sure that it's typically isotonic and pretty much pH neutral, because otherwise your lungs will react to that. And so anytime I see ethanol in nebulization, I'll worry a little bit. Anytime I see glycine in nebulization, I'll worry about it, because glycine actually has there's two types of glycines out there. There's an acid and there's a buffer. And this one is actually a buffer, and so it has a pH of 10.5. This 10.5 may not be as bad as it sounds, because sometimes the lung actually is very acidic in these patients. So sometimes it has the lung lining fluid actually has a pH of like 6, anywhere 5 to 6 in most of these kids. And so there's been quite a few studies done with prostaglandins in pulmonary hypertension in animals, and you can see them here, and I won't repeat them, but like I said, I'll provide you all these at the end. And so quite a bit of research has been done in this particular arena, and so we were happy to see this when we were exploring using it in humans, that there's been a lot of translational, if you will, research done. There's also been quite a bit done in humans as well, and you'll see most of them are very small numbers, And so a single patient here, 12 patients here, and so certainly not a randomized controlled trial by any means, but at least it's starting to set a safety profile for us to potentially study in the future. What's been done in children and neonates, here's another handful of kind of studies, once again kind of ending in 2004. Most of this probably ended because of nitric oxide. And so remember I told you nitric oxide came into existence around 2000 in our practice, and you'll notice that a lot of the studies dropped off because now you have an FDA-approved drug, and so even though it's expensive, so far it didn't drive a lot more research in that arena. And so there are a lot of people that are studying it, and will now, and so it'll be interesting to see the next few years. When I was in Dallas 3 years ago now, they were actually actively studying PGEs in pulmonary hypertension, particularly in patients who fail nitric oxide. So we're looking at it as an adjunctive therapy because it's a secondary mechanism of vasodilation, and so it may be something that's important. But it may be something that you guys could potentially use as well in your patients who are having pulmonary hypertension crises, and you want to provide a vasodilator. All right, so now the fun part. Last 10 minutes or so, I'd like to hear from you and challenge me on adjuncts that you would like to see us, and I just threw out a couple here that you may or may not want to discuss, and between me and Natalie, and we can probably figure this out and help you go from there. So I threw out Heliox. Do you guys have the option to use Heliox? No. Okay. Moving on to this next one. No. So no Heliox. All right. What about, you can't even see it, I'm sorry. You don't have Rabivir. You don't have Rabivir. Okay. You can't do prone positioning. Yay! We got something to talk about. Yeah, see, and you all do it all, right? And so all the time, so that's not really a question. Okay, so I'll be happy for you to ask me some questions about alternative therapies that you think may or may not be beneficial. Anybody willing, brave enough? Okay. Yeah, so it's the same questions with PGEs and same thing because you got ethanol. And in the beginning, we didn't think too much about it, and I was particularly very active with Prostacyclin, which has that glycine buffer, and we actually had some patients who had bronchospasms because of it, and so it's something that we certainly need to work through a little bit more, but. The rules of thumb before you aerosolize anything is typically that you want an isotonic. So most of these drugs we can make isotonic without making them unstable. Sometimes when you take a drug and you make it isotonic, then you make it very unstable, and then it won't even hold within the syringe that you're getting ready to nebulize it into. And so that's something you have to worry about. And so is the pH fairly neutral? Even if it's a little bit acidic, is the pKa, is it a strong acid or is it a weak acid? If it's a weak acid, a pH of 6.5 is not bad because albuterol, all the racemics, epinephrine, those types of things have a pH of like 3.5, believe it or not, to keep their shelf life. But it's easily neutralized by the lung when it's inhaled because the pKa is so weak. It's such a weak acid that it's easily neutralized. And so I think if you think through those, then you're probably okay with nebulizing that. But with any drug that you nebulize, you want to make sure that you look for the effect that you expect. And so a lot of times, unfortunately, we blindly nebulize things in the tube and never look back. And never go, did we actually help them? And I think that's been our problem with inhaled steroids, inhaled bronchodilators. I think there are certain patients out there that actually benefit from it. But because we give it to all patients, kind of blindly, you know, people can develop these studies that say it's not helpful at all. And so I'll worry about that a little bit. Any other inhaled medications that you guys are? And magnesium sulfate. In asthmatics or?
Both asthmatics and for pulmonary hypertension.
Oh. I haven't heard about it for pulmonary hypertension. All right. Write that one down. And so, yeah, we've definitely done it for asthmatics, particularly in the emergency room. In other words, it's been pretty helpful for us to help reduce admissions to the hospital. And so, but for pulmonary hypertension, I haven't thought about that one, but that's interesting. So hypertonic saline, that's another good one. So let's talk about that. Hypertonic saline is something we do use mainly for our bronchiolitis patients. And that's something that I think is probably pretty helpful. It breaks the rules, though, that I just told you, which is that you should typically inhale an isotonic, right? And so it breaks all the textbook rules. But that's what you want, because you want to actually pull more fluid into the airway so that they can move their secretions that they're having problems with. And so that's the intended effect, and that as long as you're understanding that that's the intended effect, that's good. I do worry about it in kids who have a history of reactive airways disease. In other words, nebulizing it in a hypotonic saline without a bronchodilator either before or with it, or prepared to give just in case they do have a bronchospasm, is probably ill-advised. And so I would say that you should, I would just proactively, if you have a kid that has twitchy airways or reactive airways, I would probably give it before giving the hypotonic saline. And we do it kind of proactively if the family has a history of asthma, if they've had eczema and those types of things, then we say, hey, they likely have a reactive airways disease, and so we just proactively give them albuterol for that effect as well. So,
bronchiolitis, you don't get anything except
hypertonic. Yeah. I think for the most part, that's fine. It's absolutely fine. I just wanted to give you that little bit of caveat, because that's one of our concerns, is that if we start blanketly using hypertonic, there's going to be a subsection of patients who we may make worse because they have reactive airways disease. Remember, a lot of the kids that we're seeing typically that have bronchiolitis that require hospitalization or intervention, they're a different patient population to begin with. In other words, they're a more patient population that's susceptible for things not going well. Because most kids have bronchiolitis and they do just fine with it. It's like, you know, it's almost like a common cold to them, and they don't need hospitalization. So we're a little bit more skeptical when you actually need hospitalization for bronchiolitis, particularly if you're a premature infant or previous history of being premature and those types of things, and all the reactive airways, asthma, and stuff like that goes along with it. And so just a word of caution, if you have someone who has a history of reactive airways disease or even demonstrated reactive airways disease, a bronchodilator with it is probably, at least for the first step, is probably okay. I'm not sure I would keep it on. In other words, if they do fine with it and you didn't give it, I wouldn't start it. And those types of things. Beta agonists, yeah. So far we haven't done the trial of. We haven't done the trial though, and it probably needs to be done because of magnesium sulfate without a beta agonist, and which one's better, and those types of things. So most of the time, beta agonists are the standard of care, and so it's really hard to do a randomized controlled trial with the standard of care. And so. I don't. Yeah. And again, we don't change doses based on size, and so.
What about hypertonic saline in case of recurrent atelectasis in a preterm baby who is having sticky secretion? We do not have domains in DNA.
I'm so glad I took that out of my talk. Because because I'm going to present that too, is that there's some evidence there for atelectasis. Hypertonic saline and atelectasis, I don't necessarily think that's probably a bad thing either. I do worry that what's prohibiting the patient from basically having normal airway clearance is probably the bigger factor. In other words, are you keeping this patient in one position too long? Are they too sedate? In other words, they can't take deep breaths and cough. Because a lot of times we pay a lot of attention, particularly on chest x-rays, to right upper lobe collapses. And sometimes we intervene when the child's not showing any signs and symptoms of a problem with the right upper lobe collapse. And so a lot of times it keeps us from moving them forward. And so activity, movement, wean and sedation to make sure they can deep breathe and cough and do normal things that clear their airway, I think is really the best. But in the short term, using hypertonic saline to help with that, those sticky secretions, particularly if you have evidence of it, in other words, you suction out kind of sticky type secretions, that makes a lot of sense.
Can you use also isotonic?
I don't know about isotonic. I know one that we don't use anymore that we used to use, and it is the combination of both, which is bicarbonate, dilute bicarbonate. And so most people don't use it anymore, but there's really no rationale why you couldn't use it. In other words, don't use the 8.4% that you use for resuscitations because that might burn the airway. But like 4% bicarbonate is actually still in pediatric intensive care journal or textbooks as a mucolytic because it elevates the pH because some of that stickiness is proteins basically that are acidic and they're sticking together. Plus it's hypertonic. And so you kind of get both. You get the pH elevation and you get a little bit extra sodium in the airway. And so that may be helpful as well. That's one drug that I'm actually a huge fan of. I'm a huge fan of kind of history and those types of things. But I look back and I see that bicarbonate got a really bad name, mainly because people were being not smart with it because they weren't. They were using the 8.4%. And trying to nebulize it or even instilling it down the airway, which is what adult intensivists used to do back in the day, and that's probably ill-advised because it's just too basic for the airways. But I wonder if we should do a trial of it because it's certainly cheaper than Neonates. Neonates is very expensive for us in the U.S. Mucomist, most of the therapists hate the smell of it, so they don't like to give it. Not because it doesn't work. It actually works, I think, fairly well. And so Natalie and I, she's getting ready to argue with me because we did a pro-con session in the U.S. about the differences between Mucomist and Neonates because Neonates became a new drug and all of a sudden it starts getting used everywhere when it was really developed for the CF patient population that has colonization, those types of things in their secretions, DNA in their secretions basically, and so that's how it breaks it down. Disulfide bonds, that Mucomist does, it breaks it down, pretty easily. And so, you have a question?
What about the nature's life
So, yeah, that's an interesting because we used to do that, and from what I recall, it was actually fairly effective. But I'm not sure why it fell out of favor, to be honest. At least in the U.S. I don't know of too many people that are still doing it. Are you guys doing it? We used to do it at UVA when I was there, and quite often. And it makes some sense that it may help with edema and those types of things. I think we're just trying to get more proactive. A lot of these therapies, I was talking to someone yesterday, is a lot of these therapies we develop for BPD are really just kind of throwing the whole kitchen sink in at the kid, and there's not a lot of evidence, and it becomes really an art of taking care of these kids. And I think, unfortunately, LASIK is an art form, and not a lot of evidence. Makes some theoretical sense, but maybe actually withholding fluids or getting their nutrition up and those types of things, or preventing BPD in the beginning, which is obviously always the ideal thing, and making them comfortable. And so if it makes them comfortable and it helps with some of their tachypnea. But I would just ask you to pick something measurable, deliver it, and make sure it actually helped that. So if you want to drop their tachypnea or improve their oxygenation by doing that, fine, do it, but make sure it actually did. If it doesn't, stop it, because there's so many unknowns with some of these drugs that I worry that us blindly using it without safety data, you could actually hurt somebody.
You don't have here for
You don't.
you don't have
Yeah. Yeah.
for the
Yeah. Yeah. I'm not. You know, we have those in the U.S. And so I don't know if they're any better or not. You know, and so
we've been using it enough now.
yeah, yeah.
Either you know about lidocaine nebulizer, lidocaine or lidocaine.
Lidocaine? Yeah, so we do that fairly often for bronchoscopies, in preparation for bronchoscopies. We also have a couple physicians that do it for NG tube placement to help reduce, you know, the negative effects of that. It's a little bit.
Safe, effective.
I think as long as you keep below the doses that cause seizures, you're fine. The only thing I worry about for like NG2 placement is that you start losing their glottic effect of closure, and so I worry that they could vomit and aspirate, particularly if they've been fed recently. But when we do bronchoscopies, we hold feeds and those types of things, and so for doing it for that purpose, I think it's probably fine. I do worry that sometimes when we have to use lots of lidocaine to numb them, that they can get that systemically and end up having a seizure and those types of things. It's rare, very rare, but it is documented in the literature that it can occur. The NG2 placement stuff is a little bit iffy to me, but I certainly don't want to make the child suffer. And so if it helps with that, then I think it's probably fine.
If there is failure of extubation because of post-extubation stridor, and you are obliged to re-intubate the baby, do you use DOAC and corticosteroids on the tube?
No. But we do, like, you know, I was telling you that we have kind of switched to more cuff into tracheal tubes. And so one thing that's been changed in our practice is if you don't have a leak when you let the cuff down, because you're evaluating them for extubation, whether you should start steroids, systemic steroids, a short course before extubating, and that's still up for debate. And like Natalie's saying, is there's not a lot of data that says one way or the other. I will tell you that kids that have difficult airways or they just have lots of comorbid conditions, we tend to favor giving them steroids because we want them to have the best chance of success. If it's a simple post-op patient that you know, had a simple surgery and they're being extubated 6 hours later or something like that, and they don't have a leak, there's actually evidence showing that that's not that big of a deal, and they'll do okay even without a leak. And so you guys don't have heliox, right? I mentioned that, yeah. So that's one of the things Natalie and I were talking about, is because we have that in our back pocket for some of these kids that have stridor that can hopefully get them over the edge, because sometimes putting the tube back in doesn't actually reduce inflammation, as you can imagine, and sometimes we're then forced to put a smaller tube in, which makes their work of breathing even higher. And so it's kind of a no-win situation. So some of those kids we try to ride out with systemic steroids and then heliox, and see if we can actually prolong that. But usually after 12 to 24 hours, if they're still struggling, then we'll certainly re-intubate them. We also try to use racemic epi in those patients, and it usually doesn't help that much. And so CPAP, BiPAP, we've also used to help, once again, just trying to reduce their work of breathing, and hopefully over time that airway inflammation will go down. That actually works, in hindsight, thinking about it, it works pretty well in neonates. Because sometimes we end up putting them on non-invasive ventilation for a short period of time, just to help them get over that airway resistance.
So, but we don't use routinely systemic steroid before sedation.
Yeah.
We should.
No.
Well, I don't do that. I don't do that.
Yeah. Yeah, we don't either.
Unless there is stridor after sedation. We don't.
Yeah, and even then, sometimes people feel like it's too late. So that's why I said sometimes we have a discussion. Do they have a leak around the endotracheal tube? And try to evaluate that patient. And if they're a patient who's going to be a high-risk extubation to begin with, they tend to side on giving them a little bit of steroids as a help. In the patients that we extubate and they develop stridor, we try to immediately get steroids in, knowing that it's probably going to be 6 hours or so of a tough time before the steroids will be effective. And sometimes that's where we set our objective limit. So in other words, we gave them steroids, we wait 6 hours, if possible, to reevaluate whether we should just reintubate them or not.
What if we try the nebulized steroids instead of the systemic steroids?
You know, that's something that is creeping up in the asthma literature about inhaled steroids. And so, in other words, doubling someone's inhaled steroids versus giving them systemic steroids. Because particularly in kids, some of the kids, it drives them crazy, it drives their parents crazy, and so it can have all types of effects. But it's something that, I don't know, I don't think it's ever been looked at, but it probably wouldn't hurt. Particularly if they're moving decent air. Now, if they're not moving any air at all, then you're just nebulizing to basically their oral pharynx, and you're probably not going to get it there. But if they're moving decent volume and have a little bit of stridor, if they're mild, moderate stridor, then I think it's probably worth a try. Putting it on the tube itself is an interesting concept as well. I hadn't thought about that.
Do you add the steroid to surfactant?
Yeah. I was going to talk to you about that yesterday. It ran out of time. Headed on a couple other slides about that because that's the latest is steroids with surfactant therapy, and so we don't at this time, but it is all over the literature the last couple months about that, and is that the silver bullet that we've been looking for? And I think the jury's still out, but I think it's looking pretty good. Yeah.
Only four together with the surfactant.
Yeah. Yeah.
How much surfactant? How much?
Only course 250 micrograms per kilogram.
Makes it and a one-time dose.
Yeah, it was just published in Critical Care, I think, 2 months ago, 3 months ago. Yeah. Yeah. We won't talk about that. Any other questions? Any other adjuncts that you're thinking about? Or?
If you have a patient like pulmonary hemorrhage or obstructed by blood clots, do you ever inject anything in the tube? Any drug?
Ooh, that's a good one. In my 20 years, I've injected a lot of things for bleeding. So we've done ice saline. Ice saline, yeah, for a pulmonary hemorrhage. This was 15, 20 years ago, so don't hold it against me. It actually stopped the bleeding, believe it or not. And so it might have made the kid a little bit cold too, and so maybe I was doing a little. Yeah. What'd you say? Adrenaline? Yeah, definitely done epinephrine. But as we've kind of looked at those things, at least in my practice, most of them don't help the end result. In other words, most of those kids that have a pulmonary bleed like that are really sick and are going to have very severe lung disease, and no matter what we did to try to stop it, with the exception of PEEP. One of the ones that I think is probably pretty effective is PEEP for pulmonary edema. But when you have a bronchial tear or an alveolar tear that's bleeding into the airway and you're actually suctioning frank blood, Like I said, we've tried cold saline, epinephrine. Epinephrine can be really problematic, as you can imagine, because you can drive their blood pressure up. And then they have an IVH, and so they have to be very careful with that. And so we try to use a dilute form of epinephrine to do that. But it's always, in my opinion, it's a mess when you have a pulmonary hemorrhage, a true pulmonary hemorrhage, not just pulmonary edema as a problem. Pete, and we've even used the oscillator as kind of a mechanism to try to stop it. But unfortunately, most of the outcomes are pretty poor when they do have that frank bleeding.
When you oscillate for a pulmonary hemorrhage, what's the mean pressure? What's your pressure?
High,
Yes,
yeah.
I've read a very high number.
Yeah. Yeah, usually that's exactly right. So Natalie's saying usually high enough to get it to stop, and so and sometimes that can be as high as 20, 25. You know, and in a small neonate, that's a lot of pressure, and so you worry about dropping their systemic blood pressure and those types of things when you're using that high. And typically, you're over-distending the lung. You're doing lots of other damages trying to stop that bleeding, and like I said, my experience ends up being a bad outcome no matter what you do. And we've tried everything, I think. And so I will say one exception is that related to airway trauma. So if you're intubating and you perforate the airway with instrumentation or something like that, those, in the right surgical hands, you can actually stop the bleeding and move forward. But if it's actually much further down the airway, it's much harder to get to, and you can't really do much about it a lot of times. So they unfortunately exsanguinate a lot of times. Any other questions? All right, thank you guys.
Thank you.